So when we published the 2013 revisions to the clinical phenotypes, we kept the older phenotypes in terms of relapsing remitting, primary progressive, and secondary progressive. And we added modifiers for activity and progression. And we did that because it allowed the clinician or clinical trialist or whomever to be able to get a time frame on what was going on with the patient. And so we took activity, for example, and we said in any form of MS, if the individuals had a relapse or a new lesion on the MRI, that's activity. And we said that ought to be noted so a patient could be either active or not active. But a key element of that was it had to be time framed. And we didn't specifically specify what that time frame had to be, but left that up to the individual. But we said at a minimum, activity should be assessed at least annually. Similarly, with patients who are in a progressive form of MS, either primary progressive or secondary progressive, we said at any given point in time, they also ought to be subcategorized as whether they were progressing or not over some time frame. And again, it could be any time frame you wanted, but at least it should be assessed annually because progression is not inexorable. So patients with progressive MS can go for long periods of time when they're not worsening, they're not progressing at all. And so that was one of the important changes that we made in those 2013 revisions. Now, more recently, both the FDA and the EMA have approved agents for relapsing forms of MS, and in that they've included secondary progressive MS with activity. Full stop. That's why we wrote this clarification piece that's just come out in neurology, because there's missing information in that characterization. And so if you're going to say secondary progressive with activity, you have to have a time frame, because by definition, all secondary progressive patients had activity at some point in time. Because to become a secondary progressive patient, you have to go through a relapsing remitting phase. And that means activity. Now, once you enter the secondary progressive phase, you may or may not have superimposed relapses or MRI activity, in which case you may or may not have activity as we defined it. And the other thing was that when the FDA discusses this in the labeling, they only talk about activity in terms of relapses. They don't mention the MRI. But when we published 2013 criteria, we specified that activity could be either, because we think that there is a certain equivalence between having a new MRI inflammatory lesion and having a new attack. Now, no one's gotten into the issue of time frame of progression as yet, but that was the main problem that we had, and one of the things we very much wanted to clarify, that we would like to see these definitions adhered to. And up to this point, when we had the first paper on the phenotypes of MS from 1996, there was a consistency amongst how it was used by clinicians and clinical trials and regulators. And now the regulators have taken a step away by not fully defining what they mean by activity. This is going to cause some confusion, and it can, in fact, broaden the group of individuals that meet that characterization of secondary progressive with activity, because now the clinician can use whatever time frame he wants to make that determination. So I think that this is going to be somewhat confusing, both for the clinicians and for the pharmacy benefit providers and everyone in between in what's meant by this. The general concept, though, still holds that when we think of activity, we think of it as inflammatory. Now, that's an assumption, that's not proven, but nevertheless, we thought of it that way, whereas progression in the absence of activity is thought to be a little more neurodegenerative. But we also know that there's inflammation throughout all stages of MS, whether it expresses itself as an attack or even as a new lesion on the MRI. And so that characterization, like dichotomization between inflammation and degeneration is a bit arbitrary and maybe even artificial. What we need to look at moving forward is studies that provide us a better sample size of both progressive patients with activity and progressive patients without activity.